Good day, everyone. On behalf of Cambridge Health Tech Institute's Global Web Symposia Series and our sponsor, Biomodels LLC, I'd like to welcome you to clinically relevant animal models of fibrosis, utilizing classical and novel approaches to evaluate potential therapies. My name is Elizabeth Lamb, and I'm the host and the moderator for today's event. Now, I'd like to introduce our presenter for today. He is Dr. Andrew Barkowski, PhD, Scientist 1 with Biomodels LLC. Welcome, Dr. Barkowski. The presenter ball is yours.
Hi, Elizabeth. Thank you for that introduction, and thank you all that are in attendance today. And I'll be speaking about clinically relevant animal models of fibrosis. So I'd first like to introduce our company, Biomodels. We are a preclinical contract research organization that is located in Watertown, Mass. We were founded in 1997 out of the Brigham and Women's Hospital. And we specialize in offering our clients highly translatable models of human disease and conditions for a wide range of clients, from startup companies all the way up to big pharma. We specialize in a number of different therapeutic areas, including inflammation. We do a number of microbiome studies, oncology studies. We do a number of pulmonary disease models, including allergic asthma and fibrosis. And today's webinar will be emphasizing some of the fibrotic models that we offer. Additionally, we offer cardiovascular disease models, metabolic disorder models, as well as neurology, psychiatric disorders, and cancer supportive care. And we are happy to announce that as of today, we've facilitated over 50 compounds into the clinic. So some of the objectives that we'll be getting to today during this webinar include a review of some fibrotic diseases, and I'll give a disease background and then some of the current treatment strategies. And then I'll move on to an overview of animal models of fibrosis. And this will include idiopathic pulmonary fibrosis, scleroderma, and dermal fibrotic models. In addition, I'll speak briefly on some renal fibrosis models that we offer, and briefly touch on a model of liver fibrosis that we are currently validating. So I'd first like to give some disease background on fibrosis. So it is currently reported that about 45% of the deaths in the developed world are related to various fibrotic disorders. And fibrosis can affect many tissues and organ systems in the body and lead to organ failure. And so fibrotic disease is generally initiated and is progressed and often driven by a recurrent or persistent epithelial injury. And this injury can present as trauma to the tissue. The exposure to various environmental toxins can be due to chronic or acute inflammatory conditions, and also be due to an infection from specific microbes. And while fibrosis is a common component of normal wound healing, when it is unregulated or aberrantly activated, it can lead to disease. And accompanying fibrosis, we generally see a lot of cell death, cellular stress, and a pathological epithelial to mesenchymal transition. And this activates a cell type known as myofibroblasts that are an important component of disease when they lay down extracellular matrix. In a normal wound healing process, extracellular matrix is a very important component of this process, but during times of fibrotic disease, this is uncontrollably activated. And so some of the components of fibrosis that have been widely studied and known are that TGF-beta activation is important for this process, and this has become one of the disease targets for drug development. So I'm briefly going to go over a number of the common fibrotic diseases that are occurring in the world, as well as the diseases that we currently have disease models for. So the first disease that I'll briefly speak on, idiopathic pulmonary fibrosis. Currently, we see about 100,000 cases of idiopathic pulmonary fibrosis per year in the U.S., with 30 to 40,000 new cases presenting each year. And this is a very devastating disease, as those who receive this diagnosis have a mean survival time of about 3 to 5 years. And this also represents a significant burden on the healthcare of the U.S., as there are about $3 billion in direct patient costs in the U.S. alone per year. Another fibrotic disease for which we have an animal model includes scleroderma, or systemic sclerosis. This is a somewhat rare disease, though the amount of patients in the U.S. is around 300,000. And while it's not as devastating or it has as much mortality as idiopathic pulmonary fibrosis, there's still a significant population of people that and a significant amount of cost on the U.S. healthcare, about $5 billion last year. Additional disease for which we have an animal model is for chronic kidney disease, and this is a much more common disease in the U.S., and it's believed that 1 in 9 adults in the U.S. has this disease, and about 50,000 deaths occur each year due to this disease, which has a large fibrotic component. And this also has quite the burden on the U.S. healthcare system, as last year was estimated about $60 billion in costs. And then finally, another very prevalent disease for which there's a large fibrotic component includes liver disease. And in the world, this is a very prevalent disease with about 24% of the total population. And in the U.S. alone, there were 40,000 deaths last year and over $100 billion in healthcare costs. So fibrotic diseases represent a very important component of an area of active research and development of drugs. So looking at this figure here, it's quite a busy slide, but as you can see, there are many common pathways in all of the different fibrotic diseases, namely one being TGF-beta. And TGF-beta is considered one of the master regulators of fibrosis and also a normal component of the wound healing cascade. So generally, TGF-beta is a cytokine that sits in a latent complex, and then when it's activated during times of inflammation or growth, it becomes freed from this latent complex and is able to signal in a SMAD-dependent manner to promote different components of fibrosis, including synthesis of collagens, fibronectin, alpha-smooth muscle actin, as well as activation of myofibroblast pathways, which leads to some of the devastating extracellular matrix deposition in disease. And in this figure here, we're showing a number of drug development candidates, and as you can see, that TGF-beta is one target that has often been targeted in disease and drug development. Additionally, we see that drugs are developed against extracellular matrix, intracellular enzymes, as well as different immunomodulatory and inflammatory components of this pathway. And this is a very popular area of drug development, and although this figure was taken from 2012, you can see that there are various drugs in different stages of clinical development, and it continues today that this is an active area of research. So at Biomodels, we have a certain criteria when developing or validating animal models that we aim to meet to provide to our clients. And so the first thing we want to see is whether the model can replicate the clinical condition. We also need to show that endpoints should be translatable to those in the clinical trials and easily interpretable. We also like to show that the underlying biology should be in the same as humans and respond to similar targeted treatment paradigms. And finally, we like to show that the model is cost-effective and can provide actionable information. So this next slide is just a run-through of a number of the disease models that are currently offered here at Biomodels, and they're split up into different organ systems. So we offer a number of lung fibrosis models, including intratracheal and intravenous induced bleomycin model. And these run from anywhere from 3 to 6 weeks in mice. We also offer a radiation-induced pulmonary fibrosis model, which can mimic some symptoms that are seen in the clinic. And then also in the next organ system, if we're looking at our skin as a model, we also have a bleomycin-induced dermal fibrosis model. And then we offer a sclerodermatous graft versus host disease model, and then additionally a radiation-induced dermal fibrosis model. And these are all able to be done in mice, and we also can do these in hamsters. Finally, we have a renal fibrosis model in which the ureter is obstructed for 10 to 14 days. And currently we have a liver fibrosis model under validation in which fibrosis is driven by biweekly dosing with carbon tetrachloride. And in addition to these in vivo models, we also offer an in vitro fibrosis model in which normal human lung fibroblasts are treated with TGF-beta, and this serves as a great model for initial screening of compounds. So I'd like to go a little bit more into the human pulmonary fibrosis model that we offer here at Biomodels, and I'll briefly go over this disease a little bit more in depth. So pulmonary fibrosis is progressive fatal lung disease characterized by lung damage and scar tissue formation. And as a result of this fibrosis, the lungs become very stiff and it's very difficult to breathe this condition. Ultimately, this will lead to lung dysfunction and death. And while this disease is idiopathic in nature, there are a number of risks that have been identified, such as radiation therapy, smoking, or exposure to other environmental toxins, or having acute lung injury or acute respiratory distress syndrome. And as I had mentioned previously, this affects about 100,000 people per year in the U.S., a mean survival of 4.2 years, and we see about 30,000 to 40,000 new cases per year. And currently, there are a few approved treatments, but there is currently no cure for this disease. Approved treatments include pirfenidone and nintedanib, which were recently approved in the U.S. So as I had mentioned before, the TGF-beta pathway is central to driving fibrosis in a number of these disease models. And in this model, it's been shown that TGF-beta mediates communication failure between an epithelial and mesenchyme, which result in a chronically activated fibrotic pathway. And due to this chronic activation, we see excessive collagen deposition that will result in fibrosis and scarring, and this decreased lung function in these models can be measured. And so here we're just showing a common CT scan of someone with IPF, and this honeycombing that we see here is common in this fibrotic disease. And then over here, we're looking at histological examination of a fibrotic lung. And here on the left side, we see more of the normal lung architecture, which is right next to some dense areas of fibrosis. So these are some things that we'll be looking at a bit more in the data that's coming up. So just to review the models again and talk a bit about our endpoints in these models. I'll be presenting data from our both intravenous and intratracheal bleomycin-induced pulmonary fibrosis models. And some of the things that we'll be looking at in terms of endpoints include histopathological scoring, detailed lung mechanics, and we're able to use this flex event, which is a mechanical ventilator that looks at different functional measurements in the lungs. You can measure pressure volume loops. You can look at elastance, compliance, resistance in different parts of the lung. And this is a very indicative or very important component for measuring disease state. Additionally, we're able to measure collagen content with CIRCOL or hydroxyproline assay, and additionally examine bronchoalveolar lavage fluid for inflammatory mediator content, or simply looking at the total and differential cell counts, more closely examining the inflammatory cells that are coming into the lung. Additionally, we have the ability to have micro-CT imaging performed, and this gives a nice image of the fibrosis in the lung. And additionally, if we want to look at some of the endurance testing, we can do wheel running with these animals as well. In this figure, I'm presenting basically how fibrotic models are running, and this specifically is the bleomycin model. So generally at day one, you give some inflammatory event. In this model, it is an injection of bleomycin, and this causes a massive amount of inflammation in the tissue in which it is introduced, and you see increases in a number of inflammatory cytokines over the first few days. And while inflammation is present throughout the model, at about 7 to 10 days, you start seeing some of the profibrotic pathways starting to be upregulated, including TGF-beta, fibronectin, being able to see procollagen 1. And this will persist until the end of the study, and more towards the end, we'll see extracellular matrix accumulation. So then when you think about these fibrotic disease models, you see initially an inflammatory phase followed by a fibrotic phase. And so as I had mentioned, one of the things that we look at as an endpoint is examination of the bronchoalveolar lavage fluid. And so here on this slide, we're showing the BAL from a naive animal as well as from an inflamed lung. And so in this method, fluid is lavaged into the lungs and then extracted. And then these cells are able to be visualized and quantified on a slide in order to look at the different types of cells that may be present in the lung. So in a normal naive lung, we see about 95% macrophages, which is a resident cell type in the lung. And so when we look more at the flamed bronchoalveolar lavage fluid, you see an increase in a number of other inflammatory infiltrating cells, including neutrophils, lymphocytes, and eosinophils. And so this is a very good idea. You get a very good idea of the inflammation that's occurring at that point of the collection. But one of the primary endpoints that we like to focus on in this model is one more measuring the fibrotic response in the model. And so this is primarily done by looking at a modified ASHCROFT score in the histopathology of the lung. So this is a modified score based on the amount of fibrosis that's present in the lung. And so as you can see, as we go from A to I, we see increasing fibrosis. So here we have, in this first slide, which would be given, or this first panel, which would be given a score of 0, kind of normal lung architecture with thin alveolar septa. And as fibrosis increases, you see some thickening of the alveolar septa. And then eventually you'll start seeing some of these fibrotic masses. And as the scores increase, you see more and more of the tissue completely covered by a fibrotic mass. And so during disease progression in this model, we generally target amount of fibrosis in the 3.5 to 4 range. And this range of fibrosis is a treatable amount of fibrosis. So once you get too much fibrosis present in the lung, any type of therapeutic intervention, you may not see much of an effect. So I'm next going to go on to explain some of the models and show some of the data associated with these models. So we offer 2 versions of the bleomycin-induced model of pulmonary fibrosis. One is an intravenous or a systemic model, and the other being an intratracheal or a targeted model. In the systemic model, bleomycin is administered once per day for the first 5 days of the study, and lungs and other endpoints are collected about 6 weeks later. Throughout the study, body weights are measured and respiratory status is noted as a good indicator of the progression of the disease. The targeted model, bleomycin is introduced intratracheally directly into the lungs, and the endpoints are gathered about 3 weeks later. And so between these 2 models, we're able to, by titrating the amount of bleomycin that is given, we can kind of titrate the severity of the disease. And so for the next few slides, I'm just going to be showing data on the intratracheal model, but the intravenous model, we see very similar kind of disease readouts. The only difference is that you have to wait a bit longer in the intravenous model, and the amount of bleomycin you need to use is much higher. So as you can see here, we have treated mice in different groups with various concentrations of bleomycin at the outset of the study. And in this first graph here, we're looking at weight change over the course of the study. And so while the vehicle control, you see kind of a steady weight gain, mice that are administered bleomycin generally see weight loss at some point during the study, but generally recover by the end. And another good indicator of the amount of fibrosis that is present in the lungs in the study is by doing a wet lung weight at the end of this study. So you can see here, as you increase the concentration of bleomycin, you see an increase to a point of lung weight, and then you kind of plateau, and sometimes you even see a bit of a drop. So there's generally kind of a peak response in all of the outcomes looking at the kind of dose response in this model. Our primary indicator, which is looking at the modified ASHCROFT score, the histopathology, as you can see here, as you increase doses of bleomycin, you see an increase in ASHCROFT score. And so you can see the fibrotic buildup here in the tissue, and this is a pretty severe amount of fibrosis. But generally, when you look at serial sections and look over 5 to 10 sections, we'll see an average, or we'll aim for an average score of about 3.5 to 4, and that's a good amount of fibrosis that's also treatable. And so another piece of data that we're looking at here in this model is the lung collagen content, and this can be determined either by a hydroxyproline assay or a circle assay. And you can see as bleomycin dose is increased, we see an increase in collagen that also plateaus. So based on this type of data, we would probably choose a dose of bleomycin between 1.5 and 2, kind of as the optimal dose for the disease model. And so, as I had mentioned previously, there is currently a couple different treatments that were approved for treating patients with IPF, one being pirfenidone, which is known to act somewhat on the TGF-beta pathway, as well as nintedanib, which is a tyrosine kinase inhibitor and has multiple growth factor receptors, targets these growth factor receptors. And then additionally, there are a number of anti-TGF antibodies that seem to be in development to treat this disease. And so these treatments are always used as a positive control, or one of these treatments is usually used as a positive control in this model. And as you can see here, this is kind of a brief history of the development of pirfenidone. It was discovered in 1976. Its antifibrotic properties were not shown in animal models until about the mid-90s. And as you can see here with this list of different animal models that was used, the bleomycin-induced lung fibrosis model was quite an important model for the progression of this drug development. And these are just a few of the publications that initially showed the effect of pirfenidone in hamsters, mice, and rats, showing their antifibrotic activity. And so when treating with these different interventions, you often have the decision whether you like to treat prophylactically or preventatively or therapeutically. So for this model, we'll be basically treating prophylactically, but there's also been good results that have been shown with a therapeutic dosing of pirfenidone. Okay, so to review this model and the pretreatment that we use as a control, here at day -1, we'll either treat with pirfenidone, and this is given twice a day per oral. And in another arm of this study, we gave anti-TGF-beta neutralizing antibody, and that's given every other day intraperitoneally. And again, we'll look at the common endpoints of weight change, functional lung changes, again, look at histopathology, as well as collagen content. So as you can see, first look at the naive group. In this study, they were given saline initially, and as you can see, a little drop in weight, but then generally they recover. When they're given bleomycin, you see a much larger drop in weight. It stays a bit lower throughout the course of the study. When given either anti-TGF-beta or pirfenidone, you see a bit of attenuation of that weight loss. So you can see as the course of the study is going that you are having some positive effect on disease. Additionally, here we have 4 panels with the 4 different groups. The naive or normal lung architecture, we see a large amount of fibrosis here in the bleomycin-treated group, and then we see attenuated amount of fibrosis here in anti-TGF-beta and bleomycin-treated groups. So you can see histopathologically that disease is improved. And this can be quantified with the modified ASHCROFT scores we had previously mentioned. So when given bleomycin, we see a significant increase in the modified ASHCROFT score. And then in animals that were treated with either pirfenidone or anti-TGF-beta, we see a significant lessening of that score. Additionally, when you look at the percent of the area of the lung that is affected, you see an increase of about 10%, and that corresponds to about a score of 4 to 5. And then when you treat with pirfenidone or anti-TGF-beta, you see significant or non-significant decreases to below 5% of the tissue affected. And finally, looking at collagen content, and here we use the hydroxyproline assay to look at collagen, we see increases in we see increases in hydroxyproline in the mice that were administered bleomycin, and then decreases when they're pre-treated with either anti-TGF-beta or pirfenidone. And so in this next bit of data, we're going to review some of the functional lung measurements that we can make and show the effects of anti-TGF-beta and pirfenidone. So what we're looking at here is a pressure volume curve. And if we first look at the naive group, these black dots, we see in the inspiration curve as the pressure is increased, the volume of the lung also increases to a point. And then in the expiratory curve, we see this area here. And so when animals are treated with bleomycin, this increases the stiffness of the lung, and we see a shift of this curve down and to the right. So if you think about it here, given the same pressure, you don't reach the same volume. So this lung is much more stiff, and you can imagine that this would make it much harder to breathe in this circumstance. So then when you treat with anti-TGF-beta or pirfenidone, you see a shift of this curve back up towards the naive curve, showing that there's been an improvement in lung function. So in addition to these pressure volume curves that are generated by the flex event, we also can measure a number of other components, and here we're showing lung elastin's vital capacity and the work of breathing. So lung elastance here increases in bleomycin administered animals, but then when you treat with pirfenidone or anti-TGF-beta, you see that this elastance then decreases, so these lungs become less stiff. Conversely, the vital capacity goes down in bleomycin administered animals, and then treatment with pirfenidone or anti-TGF-beta shows some amelioration of the vital capacity. And finally, the work of breathing, which is generated from these pressure volume curves, you see that mice that were administered bleomycin have a much higher work of breathing, and this is improved by treatment of pirfenidone or TGF-beta. So just to summarize these models, we were able to show that we have validated 2 clinically relevant models of pulmonary fibrosis by either intravenous or intratracheal bleomycin delivery. We've shown increases in inflammation, lung weights, fibrosis, both by collagen detection and histology, and significant changes in lung function. And we're able to show that 2 positive controls for pirfenidone and anti-TGF-beta were effective at treating this preclinical model of IPF. We didn't show any data, but I'd also just like to point out that we have an in vitro fibrosis assay of TGF-beta stimulated normal human lung fibroblasts, and this is a very useful tool in screening compounds to move into in vivo models. I'd next like to move on to another model of disease that we offer here. And so I'll be talking a little bit about scleroderma and dermal fibrosis. So scleroderma is a complex disease that's characterized by widespread fibrosis in multiple tissues and organs. It's characterized by vascular pathology and the presence of autoantibodies to a number of different cellular antigens. And symptomatically is characterized by a chronic hardening and tightening of the skin. And though it's a relatively rare disease, it affects approximately 300,000 Americans, and there are no known cures for this disease. But there's a large dermal fibrotic component of this disease that's easily observable, as well as fibrosis in a number of other areas of the body. So to review some of the models that we have for dermal fibrosis, one is a subcutaneous bleomycin-induced dermal fibrosis model. And in this model, bleomycin is injected subcutaneously for 28 days into the skin. And this data from this model can be observed here from a publication in 2014. And here you see normal skin and then fibrotic skin that had bleomycin injected throughout the course of the study. Additionally, we have a sclerodermatous graft versus host model that is driven by bone marrow transplant with a minor histocompatibility allele in compatible donor cells. This study runs a bit longer, about eight weeks. And then additionally, we have a radiation-induced dermal fibrosis model that we will not be showing any data from today. But basic readouts from these disease models include histopathology and fibrosis scoring. You can also look at the collagen thickness in the dermis. We can quantify collagen content and look at lung weight. That's an indicator of disease as well. So in the bleomycin-induced model of dermal fibrosis, bleomycin is injected subcutaneously from day 0 to day 27 in a marked injection site. And in this model, pirfenidone is also used as the positive control. And so here we're just looking at the weight change during the course of the study. So in both naive and saline injected animals, we see steady weight gain over the course of the study. But in animals that administered bleomycin, we generally see some weight loss. So that's a good indicator of disease. And our main readout in this model is looking at the histopathology of the skin, or measuring the skin thickness. So as you can see here, we have naive, saline injected, and then bleo plus vehicle or bleo plus pirfenidone. And by measuring the collagen thickness in these skin samples, you can see disease development or amelioration with treatment with pirfenidone. So the naive and saline dermal thicknesses are pretty constant. Then you see a significant increase in the bleomycin administered animals, and treatment with pirfenidone leads to a significant decrease here. And another indicator of disease that we have is looking at the lung weight. So generally, to get an idea of disease, as soon as the study is over, you can weigh the lungs, and these usually are a good indicator of disease. So with naive and saline, weights are relatively the same. We see a significant increase in bleomycin administered mice, and those treated with pirfenidone, we see a decrease from there. So then I'm gonna move on to talk more about our sclerodermatous GVHD model. But I first wanted to give a little background on graft versus host disease. And so The people that get graft-versus-host disease are generally patients that are undergoing stem cell transplant, and about 80% of these patients will acquire some form of GVHD, the acute GVHD, within a couple weeks after transplant. But then another 30 to 70% develop chronic GVHD following this transplant. And this can involve multiple organs in the body, including the skin, as well as mucosa, GI tract, liver, lungs, and other organs. And the disease here is dependent on the antigen-specific T cells that are originating in the bone marrow graft attacking the host. And so there's a number of different skin conditions that are observed in chronic GVHD, but the one that we have interest in this model is kind of the sclerotic chronic GVHD, which leads to fibrotic buildup in the skin, which leads to skin tightening and may decrease some joint mobility. And so in our sclerodermatous model of GVHD, we transplant bone marrow from a minor histocompatibility allele mismatched host. And as I said, this is disease induction is dependent upon the T cells present in that bone marrow transplant. So initially, in this model, the recipient receives a lethal dose of TBI, and then the following day, bone marrow and splenocytes as a source of the T cells is injected into the recipient, which drives the disease. And in this chronic GVHD model, the engraftment phase lasts about 3 weeks, and you don't see any symptoms of disease usually until about 3 to 4 weeks following this. And this model is generally followed out about eight or more weeks. And as you can see from these pictures, the mice in this study develop a pretty severe sclerodermatous lesions, and the peak of this disease is generally around day 45. And so, as I had mentioned previously, the severity of this disease is dependent upon the T cells in the bone marrow transplant. So one way that we can kind of tweak the severity of the disease is by changing the amount of splenocytes that are added to the initial bone marrow inoculum. So as you can see here, we're just first looking at the weight change, and following TBI, we see initial weight loss, but then when disease sets in around between day 21 and 28, we see kind of a rapid decrease in weight, and this is the graft-versus-host disease setting in. And then you can see here a dose-dependent response based on the amount of splenocytes that were added to the inoculum. Another way that graft-versus-host disease is assessed is a 5-criteria score that's based on weight loss, activity, animal posture, fur texture, and skin integrity. So the weight loss of less than 10% does not receive a score, but as the weight loss increases, you see an increased score. Additionally, with activity, normal mice and normal activity will not receive a score, but as the mice become less active, they'll receive a higher score. And then here, just some examples of the scoring for different postures, fur textures, and skin integrity. So you can see as the disease becomes more severe, there are many visual symptoms that are observable that contribute to this graft-versus-host disease score. So similar to changes in weight, the GVHD score is dose-dependently increased based on the amount of splenocytes that are given in that initial inoculum. And additionally, the survival is also affected by the initial splenocyte dose. So here we see about 50% survival at the highest dose, and survival improves as the fewer amount of splenocytes are given. So to review some of the data I just showed you on some of the dermal fibrosis models, we showed validation of 2 models of dermal fibrosis, either using bleomycin kind of as a targeted dermal fibrosis model, and then sclerodermatous GVHD model, which is more of a systemic model that has a very large skin component with sclerodermatous skin lesions. The next disease model that I'd like to talk about would be a renal fibrosis model that we offer. So chronic kidney disease is a disease that's caused by a number of conditions, which include diabetes, high blood pressure, different inflammatory conditions, and can also result from prolonged obstruction of the urinary tract. And left untreated chronic kidney disease can progress to kidney failure, which is characterized by accumulation of a lot of scar tissue due to fibrosis. As I mentioned, this is a very common disease in the U.S., and currently there are not many treatments that are effective at stopping the progression of this disease. So a model that we offer of renal fibrosis here at Biomodels is a unilateral ureter obstruction model. And in this model, there's a surgical ligation of the left ureter, and this is left in place for 10 to 14 days. And during this time, there's a progressive amount of inflammation and fibrosis that builds up in the kidney. And in this model, the right kidney is left unobstructed so that we have a nice internal control in each mouse to kind of assess the levels of fibrosis. So some of the common endpoints here, again, are histopathological and fibrosis scoring, inflammation scoring. We also look at collagen content. And so here we're showing data from this model, and it can be run for anywhere from 10 to 14 days. But in this study here, we sacked a cohort of animals at 7 days and at 14 days and looked at the kidney weights. And this is usually a very good indicator of the amount of fibrosis that's present in the kidneys. So here at day 7, you have the control right kidney that was left unobstructed, and then the left kidney, which underwent the UUO surgery, and you see a significant increase in weight. And this is again seen at day 14 as well. So this is a good indicator of fibrosis in disease without actually measuring collagen content. And then our primary endpoint, looking here at histopathology, we see in the control kidney normal cellular architecture. But in the UUO model, we see a large infiltrative inflammatory cells as well as large patches of fibrosis. And so that pretty much wraps up the models that we're currently running in fibrosis. So today we spoke about the current state of fibrotic disease with an overview and current treatment strategies. And then I went over a number of the animal models of fibrosis that are currently offered, including pulmonary fibrosis, dermal fibrosis, as well as renal fibrosis. I'd like to thank you all for your attention today, and special thank you to our managing partner, Dan Lichtman, our CSO, Stephen Sonis, our Chief Operating Officer, Greg Ling, as well as the scientists, technical staff, and business administration members here at Biomodels. If you would like to ask any questions, I will be happy to answer these by email. Thank you for your time.
Thank you very much, Dr. Borkowski. So on behalf of Cambridge Health Tech Institute's Global Web Symposia Series and Biomodels LLC, thank you all again so much for coming, and have a great day.